Video demonstration of Goel's technique of laparoscopic hysterectomy. Patient is put in lithotomy position, ports are placed, one primary port at the umbilicus with two accessory ports in bilateral lower quadrants. This technique does not use vaginal manipulators or myoma screws. This technique starts with dissection at the round ligament on the left side of the patient. The isthmus is held and the uterus is retracted cranially. The round ligament is cut, followed by opening the anterior leaf of the broad ligament. The next step here is to identify the ureter. The best way is to spot the ureter where it crosses the common iliac artery, dividing into the external and internal iliac artery. This dissection is best done with a harmonic instrument. Once the ureter is identified, we try to lateralize it, and then we move to dissection on the right side. The uterus is held at the isthmus and retracted towards the left shoulder. The round ligament is cut with the help of harmonic device, and we slowly go on to open the anterior leaf of the broad ligament. The section proceeds. We identify the ureter on the right side and try to lateralize it as well. Here we can see that the ureter is identified. The next step is to open the vesico-uterine fold and enter into the retrovesical space. Traction is given on the uterus cranially. There is loose areolar tissue present between the bladder anteriorly and the cervix vagina posteriorly. Remember, fat belongs to the bladder, and staying in this plane is crucial for dissection. The next step is retracting the uterus anteriorly, the rectum to the right side. This helps in identifying the posterior leaf of the broad ligament, making it taut and helping it cut down. Once the step is done, we repeat the steps on the left side. At this junction, it's very important to visualize the ureter from behind as well. The bilateral uterosacral ligaments are cut sharply over here. Next, the uterus is retracted anteriorly and the rectum is retracted cranially by holding the epiploicae, and the rectouterine folds of peritoneum are cut down to open the rectovaginal space. Remember, fat belongs to rectum. Next, with the help of a vessel sealer, the uterine vessels are completely skeletonized, coagulated, and cut. Here we are showing this process on the right side. Lateralizing the ureter before cutting uterine vessels helps in reducing the risk of injury to the ureter. Thus, lateralization is always recommended before taking the uterine vessels. This step, once completed here, is then repeated on the left side as well. When the bubbling stops, it indicates the complete coagulation of the vessels with the tissue sealer, following which the vessels need to be cut. With all the previous surgical steps followed in this technique, the uterine vessels are completely skeletonized. Hence, this is of major advantage while doing a laparoscopic hysterectomy, as it prevents bleeding and keeps the field of vision clear for the surgeon to operate carefully. The point of transection is confirmed by palpating the vagina with one instrument anteriorly and one posterior to the vagina. A vaginal pack is then placed to maintain pneumoperitoneum, and the vagina is then cut. At this point, it is important to ensure that we are not cutting through the cervix and the line of dissection is correct. Once completed, any bleeding from the cut end of the vagina can be controlled with the help of a bipolar instrument. The specimen is only hanging on the infundibulopelvic ligament. The reason this is not cut initially is to prevent rotation of the uterus, because we do not use any myoma screws or a vaginal manipulator. Depending on whether ovaries are conserved or not, the infundibulopelvic ligament is divided. The specimen is positioned in the vagina and removed by an assistant at the leg end of the patient. Closure of the vaginal vault begins at the angle of the vaginal cuff. 3-0 vicryl suture with a round body needle is used. Bites are taken involving the uterosacral ligament cut previously to prevent uterine prolapse. This technique uses the intracorporeal technique to close the vagina. In the end, the suture is secured by an intracorporeal square knot. The pelvis is thoroughly irrigated with normal saline and hemostasis is then confirmed. Thank you.